Anyway, so you guys went over the lecture about shock, right? So I looked at it and I think it covered the basic physiology and different kind of shock. So we talked about it and I thought we'll go over sepsis because sepsis is something which goes to PCU quite often. We don't see so much of cardiogenic shock there. I guess we see hypovolemic and septic shock more so than anything else. So this is kind of a recap of an article which came in New England Journal, and there was a task force which was created in 2000 and task force was created a while back, but the guidelines came out in 2012 where they defined what various institutions should do, how to go about dealing with sepsis, and the reason behind that was mortality and morbidity with sepsis is very, very high, and people were doing whatever they wanted to do and just to have a specific way of doing things. Multiple hospitals, experts from all the hospitals, they sat together and they came up with something called as these sepsis guidelines. And now that we are going into bundle payment and everything is quality measured based on that, if we as a hospital, as an institution, we follow the protocol and we show, well, 90% of our sepsis patient or 100% we manage to follow those guidelines, the reimbursements go up. So it certainly is a financial reason behind it, but also the guidelines are very good, and whether it's going to show any improvement in mortality, it's hard to say. The guidelines came out in 2012, so it's only been 3 years, so we don't have any data as yet. But if you look at it, it kind of makes a lot of sense. And sepsis is one of the biggest killer even till now in this country. So this is from that article. We did this for interns and residents. So it has, I think it's very simple. Just see, and if you think, any questions, just stop me. Okay. So we all talk about sepsis, SIRS, severe sepsis. This chart explains pretty much what we are talking about. So what does SIRS stand for? Anybody? Right. So that is something where your inflammatory system in your body is activated. And anything can activate it. So the big ones we see are pancreatitis, aspiration, trauma, we don't see that much. Burns, we don't see that much. So anything where your response, your immune system is working, is hyperactive, that's SIRS. When that immune system is activated because of infection, that becomes sepsis. So SIRS with a presumed source of infection is sepsis. So patients will come to you with pancreatitis. Gallstone pancreatitis, huge thing for SIRS. They will go into ARDS. They look very much like sepsis, but they're not sepsis because it's not infection. I don't know if you guys remember, we had a patient of cotton fever. Do you remember that? Right? So cotton fever is SIRS. Cotton fever, it was kind of a very interesting case. It's when people use cotton to filter their IV drugs, and then the pathogens from cotton gets in the blood. So very huge immune response. That was SIRS. And initially when the patient was in PCU, we thought the patient had sepsis because it looks very much like sepsis, and because the kid had injected, we thought, well, it's going to be MRSA or something, but the infection workup was negative. So that's SIRS. Anything which makes your immune system kind of go crazy. And from infection, that's sepsis. So now we kind of have infection, we have SIRS. And then in the middle is what we have: sepsis, severe sepsis, septic shock. And I'll tell you how to differentiate between those. So if you look at this, so there is SIRS, then we have sepsis, severe sepsis, and septic shock. So it's just a progression of the disease. So SIRS, we talked about anything where the immune system is activated. When the immune system gets activated, what's going to happen to your body? Anybody? just going into physiology. What happens when your white cells are activated, and what happens?
You have a fever.
You'll have fever. Exactly. So you'll have fever, you'll be tachycardic, your blood pressure will go low, you'll have third spacing, and heart rate is going up, respiratory rate is going up, metabolism is going up. So that's all SIRS. Your white count is going to go up. Then SIRS with infection is sepsis. Once you go into some kind of end organ damage, that becomes severe sepsis. So what are we thinking of in end organ damage? Renal failure. What else?
Liver failure, DIC. Or is that shock?
Shock is something where you have severe sepsis with hypotension, and you are thinking of starting those patients on pressors. So that you're going into septic shock. But yes, severe sepsis is something where you start seeing some changes in patients' mentation. So what are the systems which are going to get impacted when people have organ damage? So your heart is pumping, your cardiac output is going down. So the organs which are going to get impacted, if you think logically, would be your brain, right? So people start going into altered mental status, they are sleepy, they're different from, they're not making any sense, the urine output is going to go down, the liver function will start going up because the liver is not getting enough blood. Their GI system will stop working, they go into ileus, right? What else? Anything else? Any other system? So basically all your systems are kind of slowing down. So that goes into severe sepsis. And then septic shock is when we have tried everything and the blood pressure is just going down, and that goes into shock, which you guys talked about. And then you're thinking about giving them pressors, whether to increase their resistance, vascular resistance, or to increase their cardiac output. So that is septic shock. But we don't see septic shock in PCU because pressors are managed by intensivist. Make sense? So now if we talk about what would be, if a patient comes, and I'll just create some scenario from nursing standpoint. It's in the middle of the night, and a patient is admitted, 80-year-old guy, comes from nursing home, white count is 20,000, urine doesn't look good, and the patient is with you. How would you know a patient is progressing from sepsis to severe sepsis, and the interns or the residents should be watching out? What parameters would you use as nursing? Anybody?
Well, we just had a patient the other night who was admitted with urosepsis, and he was lethargic, and then he started to progress. Heart rate was 120s, and blood pressure slowly started to go down, and then it ended up being 60s over 30s, like 10 cc's an hour of urine, very dark, breathing fast, like 30s, and he didn't respond to 3 liters of fluids, and he started to get like mottled. And cool extremities, so he had to go for a pressor.
Exactly. So as nurses at bedside, the things which you can see, we don't do blood work every hour, every 30 minutes, right? So absolutely LFTs are going to go up, but you can only find that out if you check LFTs. So for bedside nursing, the 2 big things are mentation and urine output. So those are the biggest thing to look for. Your brain gets around 30% of your cardiac output, okay? And kidneys get some big number, 20-25%. So a big chunk of your blood is going to your brain and your kidneys. As your cardiac output goes down, that's what happens in sepsis and shock. Your cardiac output is going down, amount of blood going to your brain and to your kidneys will go down, and urine output will go down, and mentation. Those are the 2 big things to look for. Lots of time we get call from nurses, the blood pressure is low. And again, you guys can certainly teach interns. If the blood pressure is low, but the patient is mentating well, that's okay. Because, as I said, big chunk of your cardiac output goes to the brain. And if your brain is okay and alert, it's okay to be a little low. So that's kind of, if you follow this. So these are the diagnostic criteria. This is from New England Journal, and I'll send it to you guys. Read it if you feel like, the paper. So this came out just to define what sepsis is and how institutions should define it, what to do with it, and based on how much of these parameters you can meet, the payments will vary and all that kind of stuff. So if you look at it, it's the same thing what we talked about. So patients with sepsis, so we're not talking about SIRS, that's out. Pancreatitis, aspiration, cotton fever, trauma, we're not talking about that. We are talking about sepsis. A patient has come to you where we have a presumed source of infection. How do you define sepsis? What are you going to look for? So if you think about it just logically, and it's very, very logical. So you can have fever, right? Either your temperature will go up or your temperature will go low. Your heart rate will go up or low? Up. And why does heart rate go up? What's the mechanism? What's the physiology behind it? Don't try to learn these things. It's very logical. Why does the heart rate go up when you're septic?
It's fighting to overcome the,
Why? So how does increased heart rate help?
to perfuse, to further, to.
That's
for
right.
output. Yeah.
Yes, so it is certainly a response to decreasing blood pressure. So that's one thing. What else?
To increase the cardiac output.
To maintain cardiac output, yes, that's the first thing, because your blood pressure is going down, so your heart rate is going to go up. And the second thing, always remember, when you are septic, your metabolic rate is way high. So your body is using a lot more ATP energy. So when you need that much energy, your cardiac output has to go up. So when you have patients who have fever, you'll see their heart rate is high. Sinus tachycardia, right? We talk about fever being a biggest cause of sinus tachycardia because your heart rate goes up to increase your output because your end organ oxygen requirement is going up. Make sense? So you'll have fever, white count is going to go up. Why do you have tachypnea in sepsis?
If you're acidotic,
That's one. Yes. Why would you be acidotic in sepsis?
because you're not perfusing and
Mm-hmm.
your
And?
cells are not failing.
So what happens with that? You're on the right track.
And lactic acid.
Yes. Right? So that's one thing, absolutely. You are becoming acidotic because your lactate production is going up. You're not getting enough oxygen. Cells are like, hey, we need more oxygen. You're not getting oxygen. That glucose gets broken into lactate, which is acidotic. When you become acidotic, your body has to blow off CO2. So certainly your respiratory rate will go up. So that's one thing. And the second reason being, you need more oxygen, right? Because your metabolism is high. In a normal person, you're breathing around 12. Patients who are septic, they breathe around 22, 28 because their oxygen requirement, it's like running a marathon. So if you kind of see patients who are septic, they're running a marathon constantly. So that's the same response system. So if you think, so tachypnea will happen, altered mental status, edema happens, but we'll talk about why it happens, and that's kind of going into the physiology, increased capillary leak. Hyperglycemia. Why does hyperglycemia happen in septic patients?
Is it part of like the fight or flight response where your metabolic rate goes up?
So your sugar should go down. You're in the right. So your cortisol level will go up, right? When you're septic, your cortisol level goes up, right? And once your cortisol level goes up, what does cortisol do? It increases your blood sugar. So your blood sugar goes up, okay? So those are the markers. Inflammatory markers, exactly what we talked about, increased leukocytes, decreased or increased bands. CRP and procalcitonin is something which we don't do in US so much, and it's used a lot in Europe and in Asia. So again, as I said, these task force recommendations are not something just US based. The data came from US and Europe. So they have used those markers, but we don't use that Somehow it's just not a part of regular workup. CRP and procalcitonin. And going into hemodynamic makes sense, right? Your blood pressure will go down, your heart rate will go up. And then organ dysfunction, if you talk about it, exactly the same things what we talked about. So if you go into the physiology of sepsis, all this will make sense. And you don't have to really memorize any of these, right? So, and tissue perfusion variability, we talked about hyperlactemia, and you talked about mottling and decreased capillary refill. Why does that happen? Why does mottling happen in patients?
Yeah, shunting, I guess, that you're trying to.
Shunting.
Or maybe, I
No, no, go ahead.
It's like supplying your vital
Organs. Yes. So your cardiac output is going down, right? So all your peripheral vasculature is going to become tight because you don't need blood in the fingers at that point. Fingers are okay, they can do without it. Your kidneys need it, your brain needs it, your heart needs it. So there is resistance, your peripheral vascular resistance is trying to go up. Because if your resistance goes up in the veins, your heart rate, your cardiac output is going to go up. So everything is kind of tightened so that all the blood from peripheries can go to the heart and pump the vital organs.
is that a later sign? Like,
Yes.
Do you, in septic shock, would you dilate first?
Yes. Yes.
And then you become
Absolutely.
more.
Yes.
And then late sign, you're
It will be mottling. Yes.
and cold.
And cold. Exactly. Because your peripheral I'm sorry guys. Because your peripheral, completely we are talking about the end organ. Completely we are going into the capillary. Mottling is capillary, which is the very, very, very end of the artery and venous system. So when you see septic shock patients, what do they look like? What do they appear? When you see a patient in PCU and you're like, hey, this guy looks septic, how do they appear? Going back into the shock part, let's see, if you have think about it, if you have a hemorrhagic shock person and a septic shock patient, can you tell by looking at the patient which one of the two you're dealing with?
More pale, the hemorrhagic?
Yes. Logic, just use logic. Catherine. So hemorrhagic patient, you know your volume has gone down, right? You don't have enough blood in your blood vessels. So what will your peripheries do? They are going to constrict, right? So they're constricted, they look dry, they are pale, their extremities are cold. So those would be hemorrhagic shock. Septic shock patients, on the other hand, they have vasodilatation. They'll be red, they'll be flushed, they are hot. So when you see these two patients, they're opposite of each other. Once you can recognize septic shock patient, see, watch movies from Asia, from Vietnam. They show it very well. They're flushed and red and angry looking. They're cold, but they're sweating. So that's septic shock. Hemorrhagic shock is completely constricted. There is no blood going anywhere because your body is just trying to send everything back to the heart. Okay? So going to septic shock, what are the big things to think about when you're talking about septic shock? Not septic shock, sepsis. What are the big systems you have to think about where the infection is coming from?
Urine and lungs.
What else? There are three big buckets to think about. Urine, blood, not blood. Blood infection is always secondary to something. Whenever you have blood infection, always think,
It came from.
where did it come from?
So.
Urine, lungs,
pneumonia,
and
then the GI.
Abdominal.
yes, abdominal. So those are the three big ones you have to think about. And when you talk about the organisms, what are the bugs to talk about? Gram negatives, gram positives, and rarely we talk about fungus. Where do these bugs come from, if you think about it? Where do gram negatives come from? Where do they live in our body?
Stool, GI
It's
tract.
GI tract, good. So they live in our GI tract. And when people come with gram-negative sepsis, where does it usually come
Urine.
from? Urine and gallbladder.
Mm.
So rarely you'll never find patients with E. coli pneumonia, right? So E. coli, Klebsiella, Pseudomonas, GI tract, urine. Gram positives, where do they come from? Lung and skin. So staph, if we were to culture any of us, I'm sure will be covered with MRSA. I'm sure about it. So it lives on your skin and it lives in your respiratory system. So that's where the gram positives come from. Fungal infection, where do we see fungal infection? Immune compromised, yes. Central lines, TPNs, huge ones. Exactly. We don't see fungal infections, we don't see fungal sepsis in regular everyday patients. So sources, pneumonia, UTI, intra-abdominal, organisms, these are the ones to think about. So going into pathophysiology of sepsis, so what happens in sepsis is, if we think about it, there is certainly vasoconstriction going on at the end organ part, right? Because your cardiac output is going down, your body is trying to push everything to the heart. So at the end organ, they're not getting enough blood. So you have hypoperfusion going on, and something to remember in sepsis is it's causing tissue damage. When tissue damage happens, it's procoagulation. Okay? So everything, all those surface antigens, everything are getting released, and that's procoagulation. Make sense? It's like getting trauma to your skin. What happens? When your skin breaks down, what happens? Do you continue bleeding? You don't, right? You clot. Because when you have trauma, the antigens from the skin or any surface epithelium activates your coagulation system. So the same thing happens when people have hypoperfusion and tissue damage. Your coagulation system will go up. So it is procoagulant, but also at the same time, your anticoagulation system goes up. So you have patients going into DIC, they're bleeding, their INR will go up. So one thing just to remember in sepsis or SIRS for that matter, all your systems are basically kind of fighting. All your systems get activated. Cytokines get activated, complement gets activated, coagulation system gets activated, because the whole body is like, hey, this bacteria is something which doesn't belong to us, and we need to fight it. So think about it. I'm sure all you guys would have seen it. Patients who are 80-year-old and they come to you with sepsis versus a 50-year-old who comes to you with sepsis. You'll find 80-year-olds are okay. They are chugging along and their blood cultures come positive, but they're fine. They're not going into multi-system failure. It's the 50-year-old patient who comes to you who's previously healthy. They come to you with pneumonia or they come to you with flu. They will have a much more rocky course than an 80-year-old. You look surprised. Because in a 50-year-old, your immune system is so active. The responses are so active, anything which comes from outside, your body wants to fight it. So you will certainly see mortality rate is high in patients who are hospitalized with flu and are younger. Pneumonia patients, if you get hospitalized, either you don't get hospitalized and it's fine, but if you get in the hospital and if you have pneumonia, people in their 40s and 50s do worse than patients in their 70s and 80s. Because either you're okay or your immune system completely gets activated. Pancreatitis. Who dies from pancreatitis? Young people. Because pancreatitis doesn't kill on its own. Pancreatitis kills because your immune system gets activated. You go into renal failure, you go into ARDS. Not so common. ARDS, how many times we see aspiration in old people? Every day, right? Do they go into ARDS? Rarely, because their immune system is kind of sleeping and is getting old and it's not really fighting. So you have to understand sepsis is not just white cells fighting an infection. Sepsis is just a multi-system involvement. The immunity is completely acting up. It impacts your kidneys, it impacts your lungs, it impacts everything. ARDS is not infection. ARDS is an immune response. ARDS does not mean you have infection in your lungs. It means this whole physiology is getting activated, your capillaries are getting leaky, you have recruitment of white cells happening, your cytokines are going up, you have coagulation going on. So everything just leaks out. So younger people do much worse if they are admitted. Just use that on the floors and see how, just try to. So this is what we were talking about. So Surviving Sepsis campaign, this statement came out in 2012. So now we kind of understand what sepsis is all about. The question comes, how do you treat sepsis? How do you prevent sepsis from turning into severe sepsis and septic shock? Right? That's our goal, not to transfer those patients to step down or ICU, because it's not good for the patients and it's not good for the hospital, right? So if you think about these, what are you going to do? What is resuscitation? The first step, if you remember CPR, first step is, what do we do in CPR?
Provide oxygen, provide fluids if they need it.
Yes, so ABC, right? Airway, breathing, and circulation, right? So resuscitation is always the first thing. So what do you do in resuscitation? If a patient comes to you from ER to PCU with sepsis, so you have to resuscitate them. So resuscitation is oxygen, fluids, and making sure their airway is okay. Because we talked about it, the mentation is going down, their cardiac output is going down, their blood pressure is going to go down, and their oxygen requirement goes up, right? So resuscitation is the first thing. Then there is infection control, respiratory support is what we talked about, central nervous system support, and general supportive care. So talking about resuscitation, so the first answer is always fluids. So what do you give to patients with sepsis? What fluid would you give? Normal saline. Normal saline is the answer for fluid resuscitation. And why do we give normal saline and not half normal saline? Yes. Normal saline is called normal because the tonicity of normal saline is same as your plasma. If you give half normal saline, what's the sodium in normal saline? Anybody remembers?
0.9.
0.9%. 150, 145. If you look at the labs, our normal sodium is 145, right? In normal saline, the concentration is same. It's 145 to 150. If you give half normal saline, that's 75 milliequivalents. So for every liter of fluid, you're giving 75 milliequivalents. So you're giving too much water, less sodium. So that water is going to leak out. And effectively, you're only giving them half of the bag. Make sense? So that's why normal saline is the answer. Always, always, always. If interns don't agree, if the patient is crashing in front of you, even if the sodium is high, normal saline is the answer. That's the resuscitation fluid. So then the next question comes is, okay, we are giving them fluids, and how much fluid should we give? What is enough fluid? We have decided on normal saline. It's easily available, you don't have to run around, pharmacy doesn't have to mix it. So you pick a bag, you hang it. What is adequate fluid challenge? So 30 cc per kilogram is something everybody agreed on. So that's kind of the rough estimate that we use. So a patient comes to you 100 kilos, how much fluid? You say, okay, I have given, and then, okay, now we are kind of reaching the danger zone. 3 liters, right? So if a patient has come to you and all they got is 1 bag of normal saline in ER and the pressures are in 70s, and in turn is like, oh my God, we need to transfer that patient to step down or ICU, doesn't make sense because you realize they have not given enough fluid. So this is kind of the rough estimate that we use. You always have to think about ongoing volume losses. If a patient comes to you from a nursing home with diarrhea, nausea, vomiting, and they're completely dehydrated, then this amount is less. Make sense? So you always have to think what they have coming to you with. So in those patients, it might be 4 to 5 liters. So this is kind of at least some number to go by. And fluids, always remember one thing. You can always remove fluid. When in doubt, give IV fluids. Okay? You can always intubate a patient. What happens if you give too much fluid? What's the worst thing that can happen? They get overloaded. And where does that fluid go? It goes in the lungs. It goes in the extremities, who cares? Yes, it doesn't look good. Cosmetically, it's bad, but okay, whatever. It's the lungs that you're worried about. And you can always intubate a patient. And you can always give Lasix. Lasix is a wonderful drug. But if patient go into kidney failure, you're stuck. Because kidneys don't recover that fast. Once the kidneys shut down, you know you're in trouble. Because you're going into ATN. ATN takes forever. You're talking about hemodialysis. So when in doubt, give fluids. You can always remove it. And the only problem with fluid is it goes in the lungs, and lungs can be dried out very easily. Lungs don't get damaged that easy with the fluid, but kidneys die very fast. Okay, so this is kind of the rough estimate that we teach everybody. So this is, talking about the same thing. You continue giving them fluids and you wait for hemodynamic improvement. If the patient improved in 2 liters, great. Then you put them on maintenance fluid. What is maintenance fluid?
Hydration.
How much would you give as a maintenance fluid? How much water do we need to drink as us normal people in a normal circumstances? A liter maybe, right? A liter is enough. We tell 8 glasses, that's 2 liters, but nobody does 8 glasses. So a liter, if you think about it, so a liter comes to 50 cc an hour, not even that much, right? So when patients are sick, they're septic, their water losses increase because their respiratory rate is high, right? The metabolism is high. They're losing a lot more water through breathing and sweating. So once you have reached that stage that the blood pressure is fine, kidneys are fine, everything is fine, then you put them on maintenance fluid. So usually 75 cc to 100 cc is enough, because if you give 100 cc, that's almost 2.5 liters a day. And that's a good amount. So you don't need to go more than that, provided everything is controlled. When you get patients with pancreatitis, we always give them a lot of fluid, right? So what do they teach for pancreatitis? How much fluid should they be on? 250, right? Because pancreatitis is something which causes you to go into SIRS. SIRS is similar to sepsis. You have vasodilatation, capillary leak, fluid is just getting lost. So you have to keep up. So that's the fluid therapy. And then the next thing is infection control. So what do we do with infection control? So when a patient comes with sepsis, with presumed sepsis, so you always have to obtain the cultures, right? And that's something we don't do, because most of the patients are coming to us from ER. And ER should have done the cultures. And if you find the cultures are not done, always make sure the cultures are done. So the cultures you would do are urine and blood cultures. Sputum culture is controversial. Some people, latest guideline for pneumonia does talk about it, that every patient with pneumonia should have sputum culture. Not everybody is doing it. But if you're suspecting MRSA, pneumonia, some weird pseudomonas or something, then go for sputum. So cultures are a big thing. Then you start them on antibiotics. So what kind of antibiotics would you start a patient on? Broad spectrum, exactly, because you don't know what bacteria you're talking about. You don't know what's going to grow in the urine. You don't know how resistant that bacteria is going to be. So that's why it's kind of good to understand what bacteria you can expect from which source, and based on that, you will give the antibiotic. Okay, so you give them broad spectrum antibiotic, you do cultures, and then antibiotics should be given within 1 hour of presentation. And those are the parameters which get reported, and every institution now has to report it as a quality metric. Doesn't it, it's not something we get measured on. This is something the ER gets measured on, because septic patients don't come to us directly. They are coming to us from ER. So there are some metrics, and I didn't include that slide. There are very clear guidelines. Within first hour you need to do these, within 3 hours, 6 hours, so that people can, follow the protocol and improve the mortality down the road. So
What's
antibiotic,
the time frame with, I don't know if it's true or not, but they say after 24 hours is the respiratory culture not effective if they've been on antibiotics for a while, or is it?
that's the story with any culture.
Okay.
So
And
that's
what's the time frame that you?
any culture that you do should be done before antibiotic. So if patients get Levaquin in the ER and they have come to you now and you're suspecting UTI, those cultures are useless, because that antibiotic is in, you don't know if that all those E. coli are dead, we have no idea. So always do cultures before giving antibiotic. So cultures and antibiotics are something that should be done in the ER, and they are measured on those metrics. Nobody will come after us about those. So you kind of obtain the cultures, you give them the antibiotics, and the next thing is the source control. So if a patient comes to you with UTI, you have to make sure they don't have what?
The Foley.
Foley. If they have a Foley, you should change the Foley. If they've come to you UTI, make sure they're not obstructed, right? So unless you kind of take care of the precipitating agent, you can treat it, but it's not going to prevent it, and sometimes you can't even treat it. If the patient has a liter of pus sitting in his bladder, you can give as much antibiotic as you want. It's not going to treat it. Patient comes to you with dead gallbladder, you have to drain it, right? So that's controlling the source of infection. If there is a lung abscess, you have to either think of draining it or at least follow it to make sure it's improving. If there is pleural effusion, you have to think, is it empyema? If it's empyema, that means it's infected fluid, you need to drain it. So you have to control the source of infection. And then something we always talk about is, we start patients on broad spectrum antibiotics, and then we always have to look at the cultures every day to modify the antibiotics. And why do we do that?
Making sure what we're giving is treated.
So, we are giving them the right one. Yes, that's absolutely there. But if you're starting them on these broad spectrum antibiotics which kill almost everything, only things which we don't really treat with those are MRSA sometimes, because we don't start everybody on vancomycin, right? We don't treat ESBL, which is the extended spectrum beta lactamase, E. coli and Klebsiella. But beyond that, everything is getting killed. So we always look at the cultures and try to change it. Why? That certainly is the answer, that the antibiotic we are giving is the right antibiotic. And then second thing is always, it's very easy to give antibiotics. Antibiotics are very expensive. And the second is, the new antibiotics are good antibiotics and we want to save it and not have the resistance. So if you do cultures and you realize it's E. coli which is sensitive to Levaquin, hey, perfect. Let's give Levaquin and get rid of cefepime, which is the fourth generation, right? Patient comes to you with pneumonia and you put them on Teflaro. Teflaro is a 5th generation cephalosporin. It's great, it works on everything. But you realize, oh darn, it's MSSA, methicillin sensitive staph growing in their lungs. So why use that? Let's bring it down to the easiest, cheapest, simplest antibiotic. So always focus on that, and this gets lost a lot unless ID is on case. And then next thing which I think pertains a lot to nursing staff is general supportive care. So what all do these patients need? So we have given them fluids, we gave them antibiotics. So the doctor came, done, right? So these are some other things which are important in patients with sepsis. Glucose control, we talked about the blood sugars go up. What are we aiming for in these patients? What's the goal blood sugar? 150. So the numbers used to be much lower, 100, 110, but now it's 150. So we kind of try to keep it in that range. If you see the sugars are going way high, something needs to be done. Insulin drips, long-acting insulin, whatever, the sliding scale is not good enough. Glucose control. What's next? DVT prophylaxis. Huge thing in sepsis patients. So patients come to you, first of all, they're lying in the bed, they're not moving around, nothing is happening, so the blood is pooling in their legs, and the second thing is their coagulation system is active. They are going to get DVTs. Huge problem, big hospital acquired issue which is not paid by insurance companies, and it's not good for patients. So DVT prophylaxis is a huge thing, and we all think putting compression stockings is good. There is no data to show that compression stockings are good. We all do it, and everybody has it in protocol. There is no data to show compression stockings do anything good. So the treatment is heparin, Lovenox, sub-Q heparin. So every patient should be on some kind of anticoagulant unless there is a contraindication. Okay. Stress ulcer prophylaxis, do we need to give it to patients in PCU? No. We don't have to. There was a time everybody was getting Protonics. You enter the door and you get Protonics. Protonics has been shown to increase the risk of pneumonia. It goes and decreases your GI acidity, your bacteria grow, and you get pneumonia from that.
Really?
Yes, so patients do not need stress prophylaxis in PCU. Only patients in ICU who are on pressor should be on Protonics. Our patients don't need Protonics unless they come to us on Protonics, so we don't need to add it. Nutrition is a huge thing which always gets missed. Patients, I'm sure all of you have seen patients, they're sitting in PCU, they're not either eating a spoon here and a spoon there. Nutrition is a huge thing. So again, you remember we were talking about patients with sepsis, they are continuously running a marathon, right? So in us, if our calorie requirement is 1500, 1600, their calorie requirement is 3000, 3500. Nutrition is a huge thing. That's why we see patients, they come to us walking and they don't go out walking. They have muscle atrophy, everything is gone, and you're like, oh great, now you have to go to nursing home. Pressure ulcers, everything happens. Nutrition is a huge thing. Always think of nutrition, and because nurses, I think, are at forefront of providing this kind of care. And then the last thing is always talk about goal of care, and I know nurses do a lot of it. Some physicians are very good at it, but a lot of time these things just get missed. So I think these are something which is can be nurses driven. So that's kind of the treatment about sepsis. Search for new therapies. Everything has been tried. Nothing has changed. Last 50 years, nothing has changed for sepsis. Every pharmaceutical company is trying to come up with something. Nothing works. I don't know, Catherine, would you remember? I remember we had activated protein C, which came out in market 5, 6, which came out maybe 5, 6, 7 years back. Everybody was getting it. And then the data came out, it actually worsened your mortality. It's out. There is nothing at this point besides fluids, antibiotic, and the general supportive things that we talked about. So over time, things might come. Steroids. Do we give steroids to patients with sepsis? Anybody?
Yeah.
No.
Fight it out. Not really. Patients with sepsis don't need steroids. There is no data to show steroids help. Only places you give steroids are patients come to you with on steroids chronically at home. So when they're chronically at home, you have suppressed their adrenals completely. Their adrenals are sleeping. Now they have come to the hospital, they're septic, and your body wants those adrenals to wake up, but they're sleeping because we made them sleep, right? Normally your cortisol level is going to go up, your blood pressure is going to go up, everything is increased, your sugars are going up, and you can fight it. Those patients' pressures are going to tank. Okay, because cortisol, so never, always be very careful about steroids. If patients come to you on steroids from home, it gets missed a lot. They all should get steroids. So that's one. What else? Who else should get steroids?
COPD.
Yeah, but that's COPD pathway, absolutely. But steroids otherwise not really needed. So we talk about steroids in patients who are on home steroids, patients who are in shock, they need steroids. And then there are some anecdotal stuff, patients who come to you with meningitis, and that too, a specific meningitis, steroids are supposed to help. HIV infection steroids are supposed to help, not otherwise. We do not give steroids. There was a time everybody was getting steroids, but it's out. So nothing. Statins, we don't know. Maybe 2 years from now, everybody's going to get statins for everything. Anyway, statins are there for everything because it's supposed to be immunomodulators. We'll see. Patients with MI get statins, right? Acute MI, everybody has to be loaded with a statin because it's supposed to impact your immunity. So we don't know. So that's it. So I have some questions. Anybody wants to do it? Tackle it, they're very easy, but very logical. So anybody, just, so the first one, we have a classic patient comes in from nursing home with UTI hypertension, gets antibiotics, now the patient is in PCO, is lethargic, confused, and you do the vitals, heart rate is going up, respiratory rate is going up, blood pressure is going down, extremities are cold. What will be the next step in management? What would you do? Exactly. So fluid. Answer is fluids. Always fluids. No steroids. We are not at the stage of norepinephrine. Blood, patient white hemoglobin is 10, does not do anything. So now the cutoff for blood is around 6.5 to 7. We don't need to give blood to patients if their hemoglobin is not below 6.57. Okay? Unless, of course, they're bleeding in front of you. Next one, a patient comes with septic shock, again has UTI. Now the patient has come to you lethargic, confused, high fever, blood pressure are kind of low, same respiratory rate is going up, and patient now has pyelo, it seems like. White count is up, blood cultures are done, urine cultures are done. What should be done in the next hour? Yes, antibiotics. So the mainstay, antibiotics and fluids. Next one, patient comes to you, our alcoholic guy, is cirrhotic, now has come to you with altered mental status, has jaundice, and patient is not really waking up. Classic, again the same picture, heart rate is going up, respiratory rate is going up, unresponsive, you do the physical exam on the patient, has a big distended abdomen, white count is little elevated. Always remember, cirrhotic patients always present to you to the other extreme. Cirrhotic patients, white count is going to be low, might not be high. Temperature is going to be low. Okay, so this patient is kind of, look at it, the temperature is low, 91. White count is not something you would expect 25, 30,000. Lactate level is 6. Now the chest x-ray is normal, urine is okay, blood and urine cultures are pending. So what are you thinking this patient has? What is the source of infection? What is the source of infection in this patient? GI? What GI? Patient abdominal exam has a distended abdomen and a fluid wave. Exactly. So most likely the patient has SPP, right? So the answer, what are you going to do next? Exactly. So the next thing is going to be making sure you know where the infection is coming from. So you have to do paracentesis of that patient. Because you're going to start this patient on broad spectrum antibiotics, but you kind of have to make sure you're treating the right thing and what is the antibiotic of choice. So usually it's gram-negative broads in those. And then another one, patient comes to you, the same kind of picture, fevers and chills, high temperature, heart rate is going up, oxygen saturation is 92% on 100%. So patient is quite hypoxic. And the patient has, it seems like pneumonia, right? There is a bounding pulse, and the patient is there, and chest x-ray shows there is a pneumonia. Antibiotics are started. What is the next thing? Steroids, norepinephrine, or RBCs or saline. Normal saline. Fluids. Always give fluids. I know the patient is hypoxic, but the chest x-ray doesn't show patient has CHF, right? The patient is hypoxic because there's a big dense pneumonia sitting there. And if you look at just the numbers, you know the patient is becoming septic in front of you. Heart rate is going up. That means the cardiac output is going down, right? Patient is mottled, has a bounding pulse. So fluids. So always give fluids. You can always take it back. But fluids is the right answer. Okay? What happened? Why that smile?
And she said that earlier too. We missed that one.
Anything else, guys? That's it. Done. So this is the, anyway, surviving sepsis campaign which came out. Anything else? Anybody? Question?